ICP, head injury we already covered, craniotomy we covered, pituitary gland we covered. I will move on seizure. What are the reasons for seizures? First thing, I want you to think, which are the patients you monitor for seizure? Which are the patients you monitor causes? Write down on the top, fever. If you run high fever, you're going to get seizure. Hypoglycemia, diabetic patient. If your blood sugar goes very low, you're going to go in seizure. Electrolytes imbalance. Withdrawal of your medication, barbiturates, your seizure medication, withdrawal. They're going into seizure. So fever is number one. Hypoglycemia, withdrawal of your barbiturates, electrolytes imbalance, can lead your sodium, your potassium, your calcium, any imbalance in electrolytes, you're going into seizure. Hypertension, add there. If somebody has hypertension, they can go into seizure. And do not restrain, you guys have in your notes. Do not insert anything in the mouth. What position do you put your patient when they have seizure? Sideline. Sideline, you can put them. And why? To prevent aspiration. What are we preventing here? Aspiration. What is the bad seizures are? I want you to write down tonic clonic seizure. Another word I want you to write down, status epilepticus. Status epilepticus is a long seizure when your patient has. And write down status epilepticus, long seizure. When your patients stop taking their seizure medication, they can go into status epilepticus. Head injury can cause status epilepticus seizure. Are we clear? And so what do you do when your patient has a long seizure or seizure, it doesn't stop? What medication do you give them? Valium. Write down the word Valium. And second medication, Ativan. So same answer, status epilepticus. What medication do you give? Valium. And you can give them Ativan. What are these medications are? Anti-anxiety. They're not seizure medication. Write down the word anti-anxiety, and it relaxes you and relax the patient and their muscles. Are we clear? Because they become very stiff. It's not a seizure medication. What do you monitor for seizure? Airway, safety, very important. All your questions prevent them from head injury. Put the side rails padding. Put the pillow, if they are on the floor and they are hitting the head, put something under the head. Are we clear? And open the airway. What do you keep in the room if you have a seizure patient who's coming with the history? Oxygen and suction. Some question, they say your patient has long seizure, who do you call them? Respiratory. Why respiratory therapy? Because of the breathing problem. But a lot of places you don't have respiratory. But I came across a question and they said because they can help them for breathing. I want you to write down the word aura. Aura means sensation or feeling before patient gets seizure. Aura. They can feel. Tonic and clonic seizure, before they get it, they start feeling that I'm getting. They can feel, they can smell that the patient is about to get seizure. What is another word is called post-ictal. What is post-ictal? After seizure. What do you monitor in this stage? Write down the word confusion. Your patient is very confused and they are sleepy. Two things. Very important is, so we all know post-ictal period and also aura period. I want you to remember also when your patient is having seizure, medication you know, and safety you know. But as a nurse, what do you monitor for seizure? Time and duration and activities. Activities means what is their muscles were doing. Their facial twitching of muscles. Are we clear? Activities of their body. How was it? They were jerking, they become stiff, the movement of the face, twitching of their muscle, rolling of their eyes. Are we clear? But if they want you to pick up what is important in between three of them, duration. We must know how many times your patient gets seizure, how long the seizure was. So if you're writing, you must know how long was your seizure. So I covered is your seizure, and we covered about the seizure. Now, so if you know that much seizure, what is the common medication for seizure? Are Dilantin. Another one, phenobarbital. Remember, we are going to do drug section, so don't write it. We get across that drugs are, but we already did in the morning was Dilantin. We did Topamax also, and you monitor for vision on that. Now, I'm going to do your electrolytes. Electrolytes are very important, and what is electrolytes are very important here is your normal values. Everyone should know. If you have potassium level more than 5, even 5.1 is not good. Are we clear? So if they give you potassium level and sodium level 135 to 145, calcium 4.5 to 5.2 is M equivalent. Remember, is reading M and milli equivalent per liter, and magnesium. All are very good, we all should know. Number one, potassium. Hypokalemia. Hypokalemia means less than 3.5. What do you monitor patient? Underline the word weakness. Write down the word cramping. Write down the word abdominal cramping. So what happens when your potassium level goes up? You are low, you are losing potassium. Which patient are you losing potassium? Which patient? You are losing potassium. When you pee more, which patient you pee more? DKA. What is hyperglycemia? You pee more. Write down the word diuretics on the side. You are giving diuretics, what do you lose? Potassium. Diarrhea, vomiting, Cushing. And also, I want you to remember diarrhea and vomiting, and also Cushing patients you have is low potassium, and also renal problem, some of your renal. Whenever your potassium level is low, you're going in alkalosis. Write down the word on the side, alkalosis. Whether it's a respiratory alkalosis, whether it's a metabolic alkalosis, alkalosis means all your alkalosis, your potassium level is low. So when do you lose potassium? See, this is the way you memorize alkalosis. Patient lost a lot of potassium. Which patient is losing potassium when you pee more? You are having diarrhea, vomiting, Cushing patients, and you are losing your potassium. What is the patient would have when you have less potassium? Abdominal cramping. Are we clear? Muscle cramping, dysarrhythmia, and also increased sensitive to digitalis. So when you're taking digitalis, you lose potassium. Are we clear? So that also is on your thing. Now what do you do in your patient with hypokalemia? You give potassium, and do not give more than 40 MEq by peripheral IV or without cardiac arrest. Do not give simply only potassium. You mix with the fluid. What do you monitor when you are giving potassium? Cardiac, because too much of potassium affect the cardiac. And I want you to write down is when you are giving oral potassium mixed with juice. Do not give them on empty stomach. So when you are giving potassium, in your question, do not give empty stomach, number one. And liquid potassium, you mix it with the juice. And what do you monitor before potassium you give? write down renal. And what is in renal, write down creatinine level and BUN. So before you give potassium, you already know your potassium, but they're saying if the doctors order potassium, what do you check? Kidneys, number 1. Number 2, do not give them on empty stomach. Number 3, you mix it. IV, you're giving check cardiac. Food high in potassium goes in your patient, very important. Your oranges, apricots, potatoes, celery, raisin, and write down strawberries. And when you have low potassium, I want you guys to add there on the side flat T waves. Very important, your flat T waves. T waves, there is a T waves and they become flat. If you will remember in EKG, and also peaked P waves, peaked P waves, peaked P waves, they go up. And what is flat? So T waves and P waves are peaked. And also, I will write you to write down depressed ST segment, depressed ST segment. Some of the time when they give you a question with potassium and they will say if you have low potassium, what do you monitor in cardiac? At least everyone remember is what kind of T waves are flat. Are we clear? What is in also your patient are peaked P waves and depressed ST segment. 3 things you write down. A lot of time T waves they give you and you have flat T waves. And what is the reason for patient who's having hypokalemia is vomiting, diarrhea, maybe suction. Also write down suction, NG tube suction. You're removing the fluid, you're losing potassium. Diarrhea, you're losing potassium. And what do you monitor your patient when you have hypokalemia? Metabolic, we said, is alkalosis. Respiratory, all alkalosis, your potassium level is low. Are we clear? Next, I will move on, hyperkalemia. What is hyperkalemia? You have more potassium. What do you monitor for potassium is, number 1, paralysis, diarrhea. Now you have severe diarrhea when your potassium level goes high. And which patient you have hyperkalemia, write down in renal failure. Underneath, write down renal failure and write down acidosis. Your potassium is high, you're going in metabolic acidosis. Are we clear? All your acidosis, potassium is high. All your potassium is low in alkalosis. Also, what do you do for your patient when they have this problem? I want you to go here, is K-exilate. How do you lower the potassium? Go in the second box on the other side. What drug do you give them? K-exilate. You can give them is bicarbonate, underline the word hemodialysis, underline the word diuretics, and then add their fresh blood, because fresh blood has low potassium. So if you're giving blood transfusion and they're saying patient needs a blood, what kind of blood do you give them? Fresh blood. And also write down regular insulin with dextrose and normal saline IV to lower the potassium. But yes, the drug is K-exilate. Are we clear? And also you can give regular insulin with IV normal saline or dextrose, and that will help you to move the potassium level. So what drug do you give when your potassium level is high? K-exilate. Are we clear? But in your question, what blood do you choose to give if your patient has high potassium? Fresh blood. Also, you can give them regular insulin. Now, I want you to write down here, the other one was flat T waves, but here is P waves. Now, write down when you have high potassium, what do they have? Flat, opposite. Flat, P waves is flat, and T waves are peak. They are peaking. What waves are T waves? So write down that. And depressed ST segment, same in the both of them, ST segment is depressed. But remember, P waves are flat. Peak is T waves, is opposite on flat, on hypo and hyperkalemia. So everyone, when you are giving potassium, you remember you got to monitor EKG. You got to monitor heart. Hyponatremia. What is hyponatremia? Low sodium. And when you have low sodium, what does it cause? Low sodium, underline the word increase ICP. Hyponatremia, increase ICP. And confusion, and write down seizure. And write down the word water intoxication. Is whenever you have hyponatremia, means your salt is low. And what does the patient has? Water intoxication. So write down the word water intoxication. Are we clear? And when you have water intoxication, it's cause cerebral edema. What does it cause? Cerebral edema. And what does it lead to? Seizure. So what does it mean? They're retaining fluid. Hyponatremia and restrict fluid. So you go on the other side. Daily weight. Water restriction. IV ringer lactate or 0.9, normal saline or sodium. Yes, because sodium is low. You do need to give sodium. But if you have between sodium and restriction of fluid, you pick up the best answer, restrict fluid. Are we clear? I want you to write down which patient you have hyponatremia. Anybody? Which patient you have hyponatremia? Which patient? SIADH, pituitary gland. And what do they have? Too much of ADH, and they're absorbing the water. All right? Now, I will move on. So everyone remember is, what do you do when your patient has SID? Restrict fluid. What are you monitoring? ICP. Which patient do you cut down fluid when you have hyponatremia? Are we clear? Hyponatremia, it means is your body is retaining. You do need salt, but more than salt, everyone remember, you got to restrict the fluid. Simple answer. Next is hypernatremia. Hyper means more. When you have more salt, more than 145 MEq, what does it cause? Underline the word disorientation. Write down the word thirsty and dry mouth. Write down the word dehydration, hypotension, shock, tachycardia. Write down the word shock. So what happened? Your patient is hyponatremia, they're going into shock, and what are they are losing? Fluid. What do you give them here in your intervention? And which patient you have hypernatremia? I want you to write down the word diabetes insipidus, DI. And write down on the top, they have low ADH fluid. What do they have? Low ADH. Are we clear? So when you have low ADH, that means is they are having hyponatremia and also hypernatremia, and you can give them salt, and also hypernatremia, you give them more fluid. What kind of fluid? Not hypotonic solution. Hypotonic solution or 5% dextrose. So everyone remember one word. Hypernatremia means they're retaining fluid. Hyponatremia means they have is what? Dehydration. Which patient you have? SID, the first one, second one, diabetes insipidus, they pee more. Calcium question. When you have calcium low, what is low calcium does? Underline the word tetany. Underline the word Chauvistic sign, trouser sign, and they can lead into seizure. Everyone, don't think about the bones. First think about low calcium can cause tetany, twitching of muscle. Your patient is going in seizure and irritability and paresthesia. Your muscles are having paresthesia, sensation. What do you do when you have hypocalcemia? What do you do when you have hypocalcemia? Give oral calcium supplement and calcium gluconate IV, and also seizure precaution. What food do you give for calcium? I want you to write there, collard green and spinach and rhubarb and sardine. Write down the word sardine. Is very good for your calcium. How do you lose calcium? How do you lose calcium? Hypoparathyroid. Which patient has low calcium? I want you guys to write down the word hypoparathyroid. Your parathyroid gland is not producing calcium. Or write down the word thyroidectomy. Very important. Your calcium, or you are not eating enough calcium. You are not taking calcium, or you don't have enough vitamin D. See how many questions you can see. If you have low calcium, means is your patient is having low calcium, mean their risk for seizure. What are the problems for your calcium? Your patient is not having hypoparathyroid, thyroidectomy, you're not eating calcium, you're not taking enough vitamin D. And what is the risk for low calcium? Everyone remembers seizure. Everyone remember tetany, muscle twitching. What is the food comes in exam? We all know the cheese and milk and yogurt, but collard green, sardine, and spinach and rhubarb is good source of calcium. How do you improve calcium in your patient? How do you improve calcium? Because what are the other reasons your body doesn't make your calcium? This goes for your calcium. Number one is if you are immobility. Your patient is not moving around. Increase them, remember, ambulation. And number two, estrogen level is low. Estrogen level is low. When? Older female, when you have menopause. I want you guys to write down your question with calcium. Calcium is very important in exam. Your calcium, if you're not walking around, your calcium is not good. You got to put the weight on your bones. Are we clear? If you're too skinny, maybe your calcium is low because you don't have enough weight to produce. Estrogen level, immobility. Are we clear? And so those are for your calcium level. Number three, if you are smoking, you lose calcium. Some of your question. And caffeine, if you're taking a lot of caffeine, you're losing calcium. Are we clear? Now everyone please remember in your question, your medication, what medication is reducing your calcium? Steroids. See how your questions are? Maybe in a steroids question, right? Your patient is taking steroids. Which patient has low calcium? When you are taking steroids, write down the word Cushing. Cushing patient has low calcium. Which are the other patient has low calcium? Your kidney, renal failure. Your kidney is producing your calcium level also. Are we clear? Anemia and kidneys, they have high phosphorus level and low calcium. Write down that. See how many questions you got to memorize, and your questions are going to be why female patient who is 60 years old is high risk for low calcium. Why? Estrogen level is low. That is your answer. A steroids patient who's laying in a bed, are they risk for low calcium? Yes. You are not ambulating. What do you teach your patient? Ambulation. So all these are causing low calcium. Everyone, I'm giving you calcium. Where do you get calcium? From parathyroid gland. Also in emergency, when you have thyroidectomy, what does the doctor should order? Calcium gluconate. Next is hypercalcemia. What is the reason of hypercalcemia? Too much of calcium, number one. write down hyperparathyroid. Hyperparathyroid gland, you have more calcium. Or you are eating a lot of food rich in calcium. Intake. You are taking food. Maybe you are taking a lot of drugs with calcium tablet, and your body is building a lot of calcium. Severe effect of hypercalcemia, weakness, muscle weakness. Your calcium can lead to coordination of muscle. Underline that word. Constipation, depressed deep tendon reflexes. They are not moving. Too much of calcium. Very important is constipation. Also, I want you to add there, if you have hyperparathyroid, very important answer. So number one, your muscles are not moving. Deep tendon reflexes, depressed with hypercalcemia. But for your Nclex, also remember, too much of calcium can lead to constipation and renal stone. Write down the word renal stone. And too much of calcium is in the bone, not going in the bone, but is in the blood and leading to pathological fracture. What does it lead to? Pathological fracture and renal stone. Everyone keep three things in your answer. Too much of calcium causes constipation, absence of deep tendon reflexes. Number three, I said renal stone, because they are calcium and they form the stone in the kidney, and also your bones are getting weaker because too much of calcium is in the blood. What medication, what do you do? Because you want to remove the renal stone, increase fluid, diuretics, mobilize your patient, move around for ambulation, for also surgery, maybe they remove parathyroid gland. And medication, everyone highlight the word calcitonin. So calcium gluconate you give when you have low calcium. When you have high calcium, what medication you are going to give them? Calcitonin. So you guys have learned potassium, sodium, calcium, right? I'm going to move on, magnesium. When you are giving too much of magnesium, hypo, irritability, tremor. So remember, your calcium, magnesium, potassium all affect the muscle, is tremor. And also, I want you to underline the word hypomagnesium implementation. Test ability to swallow, check for swallowing, seizure precaution. And which patient you have hypomagnesium, I want you to write down underneath, why do you have low magnesium? Diarrhea can lead to low magnesium. Crohn's disease, pancreatitis can lead to magnesium. Alcoholism, gastric suction, eclampsia mother. Eclampsia means seizure. So they can get seizure because they have low magnesium. I will move on to the next page, is seizure, tetany, and dysphagia. What do you give in magnesium diet? Green leafy vegetable. And you guys have banana, peanut butter. Hypermagnesium. You have too much of magnesium. And you remember we said preeclampsia mother. They can go in seizure. And so to prevent them, you're giving what? Magnesium sulfate. And what do you monitor? When you give too much of magnesium, underline the word depressed cardiac impulses. And shallow respiration. And absent DTR. And write down the word low urine output. Three things. If your magnesium level goes high, what happened to them? Absent deep tendon reflexes, low urine output, and also your patient has what? Is low blood pressure and low respiratory and low urinary symptom. What do you do? IV discontinue. Whatever you are giving magnesium sulfate, you stop. Number 2, what do you monitor your patient? Cardiac dysarrhythmia. And what do you give your patient here? IV calcium gluconate. That's an antidote for magnesium sulfate. So everyone remember magnesium sulfate, who you are giving? In preeclampsia mother. What is the mother is going here? In magnesium toxicity. And what do you monitor? Absent deep tendon reflexes, low respiration, low urinary output. So we finished. We did burn in the morning. And we finished with the burn assessment, superficial burn, deep, partial deep burn, and also full, and we did the wound care in the morning. I want you guys, those who came late, underline the word isotonic fluid. You give them ringer lactate, and medication, I said, silvadene cream and sulfamyolone. And closed, when you have a closed wound, you are covering, you use silvadene. If they have open wound, then you use sulfamyolone. Now I'm going to go Addison disease. Addison disease is disease of what? What system? Endocrine. What part of endocrine? Adrenal gland. And write down the word, they have low steroids. Are we clear? What is the word we call for steroids is glucocorticoid. So make sure you guys know glucocorticoid is a steroids. Mineral corticoid is a steroids. Androgens. And what part of gland is affected? Write down adrenal cortex. Are we clear? So Addison is disorder of adrenal gland. Where is your adrenal gland? Where is your adrenal gland? We have two right here on the top of the kidneys. Are we clear? And what is adrenal gland is producing? Your steroids. Are we clear? So what is Addison disease is? Low steroids or non-steroids. So their body has less steroids. What is the problem with Addison patients are, number one, they feel very weak. Underline the word is, it says tan, eternal tan, and I want you to write down pigmented skin. What kind of skin they have? Pigmented skin or bronze skin. Some of your questions, they may not use the word tan, and they may say, what kind of skin? Bronze, B-R-O-N-Z-E-D. And also, they have skin color pigmented. So pigmented, tan, and bronze skin. What is low here? Underline the word sodium. So I'm writing it like this. Make sure you write down low sodium, low sugar, and low blood pressure. What is high? Potassium. What is high? Calcium. Are we clear? So Addison patients have no steroid. And what is low? Sodium. What is low? Sugar. What do you monitor? Low blood pressure. And also write down they're losing weight. Addison patients are losing weight. So make sure you add that. And so what are you monitoring? The blood sugar. Sodium you lose, salt in exercise and sweating. So avoid sweating, avoid exercise, summertime. And they're craving for salt. Give them salt. When your patient comes in, what do you monitor? Blood pressure. Apply your question. What do you monitor? Low sugar. They are hypoglycemic. And so they are very weak. They are hypoglycemic. The body has low salt and low sugar and low blood pressure. Now, and their potassium level is high. Now, I'd like you to write down there in your treatment. So let's go in the second box. High protein diet, high carb, high sodium, but remember, restrict their potassium. They are very high potassium. Lifelong replacement. What do you give lifelong replacement? What are you giving lifelong? Treatment. Write down the word medication. What medication are you going to give them? Is write down mineral corticoid, or underline, write down the word florinef, and or maybe they're saying steroids. So what do you teach when your patient is going home or they're taking steroids? What do you teach them when they're taking steroids? What do you teach them?
Gradual.
Don't stop. If they stop, what happened? They're going into Addison crisis. Avoid stress. Very important. Are we clear? So how do you treat them? By giving a steroid. What do you increase in their diet? Maybe sodium. You can give them more sodium. You already know mineral corticoid. You already know what you're going to teach them, how you're going to treat with them. So your picture is patient goes in Addison crisis. So let's go underneath. When they go in crisis, write down they stopped medication. Why do they go in crisis? Either they are in stress and they stop the steroid. So write down on the side. And what happened to them? Severe hypoglycemia. And write down potassium level goes high. And dehydration, abdominal pain, and the blood pressure is low. So Addison crisis comes from when your patients stop the medication. Are we clear? So what happened? The potassium level goes high, your sugar goes low more, salt goes low, blood pressure goes low. What do you do if your patient has crisis? Your answer, underline the word, give sodium chloride and hydrocortisone IV, steroids. You got to give steroids, you give salt, and write down the word, you give sugar, and monitor vital sign and bed rest. So you treat them for shock. Everyone is okay? What is Addison crisis? Or when you stop medication and patient is going into adrenal crisis. What are the sign and symptom of adrenal crisis? Are low sodium, low sugar, low weight, high potassium, high calcium. Are we okay? Next is Cushing. What is Cushing? Too much of steroids. And what do you write down here? Like this. I wrote it here. Now is opposite with Cushing. They have more sodium, write down, more sugar, they have high blood pressure, they're gaining weight, and they're losing potassium, and they're losing calcium. Go ahead and write. And too much of steroids, or when you're giving too much of steroid, your patient is turning into Cushing. What kind of the problem your patient? So first thing, I want you to write down isolation. What isolation are you going to put them in? Reverse isolation. Don't put them with anybody with infection. That's important. And underline the word is monitor for blood pressure. And the skin, purple skin means they're bleeding, bruising, moon face, tunical obesity. Upper, they're big, legs are skinny. And what do you do for tunical obesity? Loose clothes. Teach them to wear loose clothes. What do you monitor when your skin care is purple? They're bleeding. Skin care. Turning them. Infection, we already talked about it, osteoporosis. And I want you to add their hyperglycemia. Their sugar is very high. Cushing patients are low carb, low calories, high protein, high potassium, and low sodium. So low carb, low sodium, low calories because they are gaining weight. Monitor glucose level. What is the treatment for Cushing is adrenalectomy, removing adrenal gland. And also what are you removing? Hypophysectomy. What is hypophysectomy? Pituitary gland, because your master gland. I want you to write down under adrenalectomy, if they give you a question, your patient has adrenalectomy, what do you monitor? So I want you to write down when they remove. Remember, there may be a question, unilateral. One, bilateral means both. So if you remove bilateral, both, you will need a steroids all life. If you are removing only one, maybe you need a steroids for 4 years or 5 years, not all life. That's number one difference. So either they're removing one or they're removing both. So when you remove one or both, you got to replace a steroid. So you're going to tell your patient they will live on steroids. Are we okay? Second thing, I want you to monitor after adrenalectomy. So you give them IV steroids. And number 2 is monitor their vital sign and electrolytes. What electrolytes? Sodium, potassium, and calcium need to monitor. And vital sign is your blood pressure, because adrenal gland is maintaining your vital sign. And very important, bleeding. Any surgery you come back, your first priority is bleeding. Your second priority here, check the vital sign, because adrenal gland, Addison has a low blood pressure, Cushing has high blood pressure. Are we clear? So what do you monitor your patient here? For adrenalectomy, these are your answers. Everyone is okay? What is adrenal gland is responsible? Producing the steroids. Now, I'm going to go into phenochromocystoma. What is phenochromocystoma means is your patient has too much of, underline the word catecholamine, and underline the word epinephrine and norepinephrine. And which patient do you have them? Write down the word tumor in adrenal medulla. So this is also adrenal gland. What do you have in adrenal gland is medulla, part of medulla. What is there? Tumor. And what are they producing? Catecholamine and norepinephrine and epinephrine. So what happened to the patient? Their blood pressure is very high. It's called persistent hypertension. And hyperglycemia, headache, and visual, their eyes will be a problem. Next side you will go, what test do you do? 24 hours urine test is called vanilla mandelic acid test, VMA. VMA test is done for diagnosing phenochromocystoma. Avoid emotional and physical status, and write down the word. How do you avoid physical and emotional? Quiet room, non-stimulating room is very important to control their blood pressure. Avoid coffee and stimulating food. Write down the word quiet environment. Less visitor, phone call, limit them, right? Because it's in the phenochromocystoma, is a tumor. And also adrenalectomy, and they will do them. So how do you treat them? By doing adrenalectomy. So which patient are you doing adrenalectomy? For Cushing and phenochromocystoma. Everyone is okay? What are the diseases of adrenal gland? Cushing, Addison, adrenal crisis, you should know, and also you should know phenochromocystoma. Everyone is okay. I think let's take a quick break and we'll finish some more and then we'll continue tomorrow. All right. Let's just, for Addison, everyone is okay. We already talked about parathyroid gland and Addison glands, and we talked about the diseases. COPD, very important. We did a lot of lungs. We didn't do COPD and pneumonia, and we are going to go now. So what is COPD? Chronic obstructive pulmonary disease. What are the disease comes here? Write down the word asthma. Asthma is COPD. Chronic bronchitis. If you have chronic bronchitis, that's also your COPD. And very important, emphysema. So when they give you, your patient has emphysema, that's a COPD. But I want you to write down in the blue bloaters. What is the blue bloaters are? The color is blue. And what is the word is blue bloaters are? Write down the word cyanosis. Remember when we say cyanosis, they're blue patients, right? They're having lack of oxygen. So which patient has blue bloaters? Their colors are blue. Which patient? I want you to write down when they become COPD, chronic patient. And they become chronic and they have obstructive pulmonary disease, they will have blue bloaters. Which are the one pink puffers are? What is pink one? Their color is pink. They are having, write down the word dyspnea. They are having difficulty in breathing, but write down no cyanosis. And which patient you will say? I will say emphysema. So some question, what do you monitor patient who has emphysema? How do they look? They will say pink puffer. Are we clear? But if they become chronic COPD question, then you will use the word blue bloaters. Blue bloaters mean the color is blue. Pink puffered mean they have dyspnea but no blue. Are we clear? I want you to write down the wording here. What kind of chest they have in COPD patient? Barrel chest. What kind of chest is here? Barrel chest. So write down the word barrel chest. And what else do you monitor? Underline the word changing in posture. Don't sleep laying down. Sit erect. So write down the word orthopenic position. So the meaning is they're sitting orthopenic position. That means they don't want to lay down. They're sitting. And maybe they're leaning on the table, and that is called, and another word they use, trapezoid position. So write down the word trapezoid position or orthopenic position. Means they are leaning on the table. They're not laying down. And also they're using accessory muscle for breathing. What is the meaning accessory muscle? Intracostal muscle. Write down the word intracostal. So when they're having a hard time to breathe, they're using intracostal muscle. So when they're saying that. Now, I want you guys write down some of the material in CO. You don't have everything here, and I want you to write down COPD patients, we all know barrel chest. And also, I want you to write down clubbing of finger, because they're not having oxygen at their clubbing of finger. Very important, two words here. COPD patient barrel chest, clubbing of finger, and number 2 and number 3 on X-ray. When you do X-ray, you will see hyperinflated lungs. Hyperinflated lungs. The meaning is their lungs are inflated. What air they take in, it doesn't comes out. So their lungs looks big, hyperinflated. And what is under the lungs? We have a diaphragm. So write down the word diaphragm is depressed or flat. Write down the word flat. So what happened? Because the lungs are taking more space, your diaphragm is flat. And patient is having these in X-ray. Number 4, they're losing weight. And why they're losing weight? Because of hypoxia. Because of they're not getting enough oxygen, they get tired. Number 5 is a skin problem, a skin breakdown. Their skin, because they are very skinny and they are risk for skin breakdown and they are sitting all time. So remember like that. I want you guys, they're losing weight, trapezoid position, problem in their skin breakdown, cyanosis they have, and also I said clubbing of finger. Are we clear? What do you do implementation? Number 1, airway clearance. Make sure airway and give listen their lung sound. Give them oxygen 1 to 2 liter, not too much because they're trying to CO2 necrosis. So any patient with COPD, what do you give them? Only less oxygen, 1 to 2 liter oxygen. Fluids is important for all your lungs patients. Why? To loosen up the secretion. Small frequent feeding because they're losing weight. And also I want you to write down there, write down losing weight, what do you do? Small frequent meal. And also write down the word increase calories, increase protein, increase vitamin C, and also increase all the vitamin, protein, and calories. What are you increasing here? Calories. What are you increasing here? Protein. And also small frequent meal. MDI, meter dose inhaler. write down inhaler or write down bronchodilator. You got to give bronchodilator. And write down with bronchodilator steroids. You give them. And also write down them is you can give them CPT if they need it. And also postural drainage. But very important, your inhaler, bronchodilator, and steroids you can give them in acute stage. So I want you guys, everyone, write down the word complications. Very important for Nclex. What do you monitor patient who's having COPD? Number one is core pulmonary. What is core pulmonary means? Right side of the heart, right side of the heart is failing. Are we clear? So right side heart failure, number one complication. Number two complication is polycythemia. All their blood cell would be high. Poly means more, cythemia means blood cell. Your hematocrit, hemoglobin, and all the labs would be high. Number three, respiratory failure. So everyone remember your question. Core pulmonary, right side heart failure, polycythemia, respiratory failure are the complications of COPD. I want you to write down one more thing. What is COPD are what they are breathing in, and the lungs are over alveoli over distended. So some question they will say over distension of alveoli. The air doesn't go out. And so what happened in COPD patient, I want you guys to write down one more thing, is what is the problem with them is their lungs are over distension of alveoli. Alveoli over distended. So everyone, COPD is leading into heart failure, polycythemia, and what is right side heart failure is your COPD patients. Are we clear? And also, what do you monitor your patient? Give them only oxygen, very limited. What is the reason for COPD is smoking. Smoking leads to your COPD problem. Next page is they are coughing and they have adventitious breathing. I will go on pneumonia. Pneumonia isolation is droplet. Write down the word droplet, isolation. Then you will go on pneumonia assessment. Is a fever. Leukocytosis, their white blood count is high. Underline the word, they are coughing and they have rusty green and yellow sputum. Next is dyspnea. They have difficulty in breathing. And pain and tachycardia. How do you, isolation, we all should know droplet. And how do you diagnose them? By chest x-ray. Write down underneath. How do you treat pneumonia? By antibiotic. And write down before antibiotic, what do you do? Sputum culture. So write down sputum culture before you start antibiotic. But how do you diagnose pneumonia? By chest x-ray. And what do they say in x-ray? Infiltration or possible pneumonia. Your patient has pneumonia and you're giving them antibiotic. Are we clear? What do you monitor your patient and nursing intervention? Listen the lung sounds. Number one, deep breathing exercise, and write down, turn them. Turn frequently in the bed. Get them up in a chair. So if you have a patient with pneumonia, not only turning, but get them out of bed. Deep breathing exercise. Chest physiotherapy. And also, I want you to write down the word CPT. And before you do CPT, write down the word bronchodilator, CPT like this, and postural drainage. All these for your lung patient. You got to open up the lungs. CPT, you do before CPT, give bronchodilator. postural drainage, you remove the secretion, turn them on the position that you can remove their secretions. Are we okay? And then I will go on. Fluids is important. Antibiotic, incentive spirometer to open up the lungs. Position, semifowlers, oxygen, bed rest. And you can go mucomist medication. You give them cough syrup. You give them bronchodilator and antibiotic Bactrim. So everyone is, your pneumonia is droplet precaution. We are going into the cardiac problem. What are the cardiac problem are acyanotic congenital heart problem and cyanotic. What is acyanotic? When they give you normal color, they're not blue. Cyanotic means blue babies. And what is the problem with them when they are acyanotic? It's a heart problem. Small statures, or write down the word failure to thrive. Failure to thrive, murmur. And they get respiratory infection. So what is one of the sign and symptom when you have acyanotic babies are their normal color, but they don't grow up, their heart murmurs are there, respiratory infection. What is cyanotic means are cardiac problem and congenital cyanosis and underline clubbing of finger. Underline the word failure to thrive. You keep moving and they can go in seizure. Difficulty in eating. Mother says when I feed my baby, they get tired. Murmur, respiratory infection. Very important is your clubbing, failure to thrive, and murmur. Are we clear? And next is acyanotic disease. What is acyanotic disease are? They are congenital. There is ventricular septal defect. There is a problem in the ventricular septal defect. When do they close? Second line, age 3. When the child goes age 3, they should be okay. If it doesn't get okay, they have to do the surgery. Second one, you go atrial septal defect. Go on the other side of the page. Atrial septal defect means both atrium has a defect and opening. And the child, it should go away. If defect is severe, they may have to do the closure. That means the surgery. PDA, patent ductus arteriosus. What is patent ductus arteriosus? And failure of fetal structure and duct arteriosus connect the pulmonary, underline the word, the pulmonary artery connect to the aorta. So they are bypassing the lungs. Are we clear? What is PDA means is patent ductus arteriosus, and the blood is not going towards the lungs. And then it can lead to last two line, right ventricular hypertrophy, and they have to do the surgery. So patent ductus arteriosus is acyanotic disease. Coarctation of aorta, that's also acyanotic. What is coarctation of aorta? Narrowing of aorta. And also when it narrows of aorta, the weak and absent pulse to the lower extremity. And write down the high blood pressure and high pulse is in the upper extremity. Coarctation means upper extremity face, they have more blood. Lower extremity, they have low blood. They have to do the surgery. Pulmonary stenosis. What is pulmonary stenosis? Is in the pulmonary artery. And also it causes right ventricular hypertrophy, and they have to do the surgery. We are on page 22. And congenital baby's heart problem, there is acyanotic and cyanotic. Acyanotic means there is no blue color. And remember, what are the problem are? Ventricular septal defect, atrial septal defect, patent ductus arteriosus, coarctation of aorta, pulmonary stenosis, and aortic stenosis. Are we clear? So all of them, they have to do the surgery. All right? And cyanotic comes your blue babies. They are born blue and they're not getting oxygen. So what are the problem with the babies are? It's called tetralogy of Fallot. What is in tetralogy of Fallot? ventricular septal defect, number 1. But there are 4 defects, and pulmonary stenosis, overriding of aorta. And remember, the child would like squatting position, and they have to do the surgery. Transposition of great vessel and pulmonary artery leaves left ventricle, and aorta leaves right ventricle. So transposition. Next is truncus arteriosus, failure to separate and division of pulmonary artery and aorta, rather than they have separate vessels. So that also is congenital. Total abnormalities of venous return, and that also can cause. But everyone should know your tetralogy of Fallot and transposition of great vessel goes in cyanotic. What does cyanotic mean? The babies are blue. Clubbing of finger. Remember, we have underlined sign and symptom on page 21. So when your babies are congenital defect, now what do you do? Monitor. Congenital heart babies are, underline the word tachycardia, polycythemia, and increasing red blood cell, knee chest position. They like to go on position. Now, I want you to go and write down here. If child has that spell in your question, and also if they're saying tetralogy of Fallot or cyanotic attack, a baby become blue, what do you do? Number 1, knee chest position. So write down the word, put the baby in knee chest position. Number 2, give oxygen 100% and by mask. And number 3 is give morphine IV. When you give morphine IV for pain and IV fluids, and you can give them normal saline, IV fluids. So these are 4 answers for tetralogy of Fallot babies are. And how do they treat them before surgery? They have to do surgery. And before surgery, you teach the mother for digoxin, apical pulse, and give them with food, digoxin for the babies, and monitor for low pulse rate, side effect vomiting of digoxin. Are we clear? And how do you give digoxin? By using syringe, needleless syringe or dropper. Don't use the teaspoon. Give the milk or formula small and frequent interval. Because remember, they get tired. So give them small formula, small milk amount. Don't give a lot of feeding because they get tired. And rest in between feeding. Very important, your teaching question. So everyone remember, we have congenital heart problem, acyanotic and cyanotic. Tetralogy of Fallot comes in cyanotic. What is the side problem with the babies in cyanotic are clubbing of finger. Are we clear? And also they get tired easily when you're feeding them. So this is what you will feed them. And so I will move on, page 23. We'll do a few more minutes and then we'll stop. Congenital heart abnormalities, prevention. We already said digoxin. They may need to get digoxin, diuretics, potassium. Feeding pattern is important. Now I'm going to move on in cardio a little bit. We did earlier today, we did is angina and we did MI. Now you're going in CHF. What is CHF? Congestive heart failure. And what is the problem here? Write down the word low cardiac output. When your heart is failing, they're not pumping. And what happened? They are retaining fluid. So write down the word CHF. Sign and symptom of CHF. Weight gain, number 1. Number 2, tachycardia, their pulse rate is high. And number 3, tachypnea, is their respiration. So they're gaining weight, they're retaining fluid. So remember, what are they retaining here? Fluid. Where is the fluid they're retaining? In the right side of the body, peripheral, and left side is in the lungs. This is periphery, all over right side. So let's see left side heart failure. I want you to write down. So 3 sign and symptom of CHF: weight gain, tachycardia, tachypnea, very important. And what is CHF? They are retaining fluid. What are they retaining? Fluid. I want you to highlight the word is left side is the lungs. Lungs are affected. Right side, I want you to write down the word periphery, all over, systemic. And what does in the lungs they have left side? Any breathing problem, dyspnea, orthopnea, underlying pulmonary edema, and also I want you to add there nocturnal dyspnea. What is a nocturnal means? Nighttime dyspnea. They cannot breathe in, nocturnal dyspnea, in nighttime. And they are weakness, and also they can get changes in mental status. But very important, anywhere breathing problem come, pulmonary edema, that means you have left side heart failure. Nocturnal dyspnea, they feel very hard to breathe in the night time. Right side heart failure. What is in right side heart failure are, I want you to start is from the neck. And what do they have here is the distension in the neck vein, jugular vein distension. So in right side, first thing write down jugular vein distension, then neck vein. Second thing, ascites, write down the word ascites. They have fluid. And before you go dependent edema, right side mean systemic problem. All your system is affected. And what do they have here is knuckle rigidity, ascites. Now you go dependent edema. When you have ascites, underline the word liver enlargement, hepatomegaly, and write down splenomegaly. Everyone, whenever you have ascites, you have hepatomegaly and splenomegaly. The spleen is big, liver is big, and below that they have dependent edema. That means below stomach. What is dependent edema? Your thigh, ankle has swelling. And also cold extremity. All your CHF patient, write down the word they gain weight because they are retaining fluid. So what is CHF? Retention of fluid, and they are gaining weight. Write down the word hypertension. And nocturnal diuresis. So they get up in the night time to pee. They don't pee in the daytime. The other one has nocturnal dyspnea. This is nocturnal diuresis. They pee in the night time, they retain fluid. What do you do the treatment for CHF underneath? Your CHF patient has what? Digoxin, diuretics you give them. And when you give diuretics, what do you monitor? Write down the word blood pressure. Because when you take out a lot of fluid, your blood pressure drops. Hypertension. And write down the word potassium. So what are you monitoring when you're giving diuretics? Potassium and the weight and hypotension. Are we clear? Next thing is diet. What diet do you give them? They're retaining fluid. Sodium, low calorie diet, low residual diet. Oxygen, give them oxygen, is daily weight, and give them medication. I want you to write down there, check the abdominal gut. What do you check? Abdominal gut. And already you said diuretics, you give them potassium. Diet is important, restrict sodium, and very important, restrict fluid. Don't give more fluid. INO, very important. What do you monitor for your patients? INO. What do you monitor for your patients when they're gaining weight? The weight every time, regularly. And what are you restricting? Fluid. So very important, CHF is fluid retention. And where do you have swelling? Systemic and lungs. Are we clear? Right side CHF and the left side CHF. And so everyone should be good on that. I'll finish this side. Arterial vascular disease, and you have venous peripheral disease, and we call peripheral vascular diseases. Now, when you have arterial, your skin is very cold and shiny. Arterial, underline the word, cold and shiny skin. Ulcer, it can also cause gangrene. Arterial is causing claudication with pain, and walking pain relieved with the rest. Decreased peripheral pulse. What do you do when you have arterial vascular problem? Foot care is important, very important. Stop smoking. And what comes in arterial vascular disease? Berger disease. Write down the side, Berger disease. And Berger disease, what do you teach them? Stop smoking. Smoking is not good for your arterial circulation. Are we clear? And also regular exercise. And medication, vasodilator. And anticoagulant. What is vasodilator? Your blood pressure medication you can give them. Venous problem. So remember, in arterial, the skin is shining. In venous, you have brown color of the skin. Underline that. And decreased pulse. Positive Homan sign. That means is what? It can lead to peripheral vascular disease, and underline the word DVT. What is DVT? Venous problem. What is Berger disease? Circulation, arterial blood vessels. And also, what do you monitor? Peripheral pulses. Monitor, give them stocking, anticoagulant, and elevate them and warm compress. Write down for DVT. So what is DVT? Is venous peripheral vascular disease. And what do you do when somebody has DVT? Positive Homan sign. What is the sign of vascular problem? The skin color is brown. I think we'll stop here. And tomorrow I will start on page number 24 on the other side. So we have done good.